This presentation will demonstrate the major topographic features of the neck. The chief bony features at the inferior limit of the neck are the superior border of the manubrium, the clavicle, and the acromion and spine of the scapula. The manubrium, with the medial ends of the clavicles at the sternoclavicular joints, is readily palpable. They form the suprasternal notch. The clavicles can be followed laterally to the acromion, and the acromion to the spine of the scapula posteriorly. The chief bony features of the superior limit of the neck are the inferior border of the body of the mandible, its angle, and the posterior border of its ramus, which separates neck from face. These are followed by the external auditory meatus and mastoid process. From the latter, a bony ridge or superior nuchal line passes posteriorly to the external occipital protuberance in the midline, which separates the neck from the cranium. The mandible can be palpated from the mental symphysis in the anterior midline to the angle and then up the posterior border of the ramus. Behind this is the external ear with its meatus. This is followed by the mastoid process. From its superior part, the superior nuchal line can be palpated and followed to the external occipital protuberance in the posterior midline. The line and protuberance demarcate neck muscles below from scalp above. In the anterior midline, the first palpable landmark below the mental symphysis is the hyoid bone. It lies below the posterior part of the floor of the mouth and can be felt to move forward in protrusion of the tongue. It is horseshoe-shaped and has greater or lesser cornua, or horns, on each side. It delimits a suprahyoid from an infrahyoid region of the anterior neck. The thyroid cartilage is palpable below the hyoid. It has a projecting carina with a superior notch in the midline. Laterally are right and left laminae. The cartilage encloses the larynx. The glottis lies deep to the mid-carina. Immediately below the thyroid is the cricoid cartilage, which is narrow anteriorly and broad posteriorly. Below it, the cartilaginous rings of the trachea can be followed down to the suprasternal notch, where the trachea enters the thorax. The hyoid bone lies at the level of cervical vertebra 3, the superior border of the thyroid cartilage at 4, and the cricoid at 6. Note that all of these and the trachea move upward in deglutition. The cricoid marks the transition from larynx to trachea, and posterior to this, from pharynx to esophagus. Note also that no major structures cross the hyoid, thyroid, cricoid, or trachea anteriorly. Hence, a vertical incision in the midline through skin and fascia directly into the trachea, or a tracheotomy, may be a simple emergency procedure in obstruction of the larynx. The incision should be below the cricoid and above the suprasternal notch. It should not extend down into the notch. In the posterior midline, the nuchal groove passes down from the external occipital protuberance to the spine of cervical vertebra 6. The rounded columns on each side of the midline are formed by the semispinalis capitis, covered by the trapezius muscle. Two muscles of the neck are of primary importance in topography: the sternomastoid and trapezius. The sternomastoid forms a conspicuous column on the anterolateral neck. It has a visible manubrial and clavicular head of origin with a depression between them that overlies the internal jugular vein. The muscle passes up and back to insert on the mastoid process an anterior half of the superior nuchal line. The sternal part is made more conspicuous by attempting to rotate the head to the opposite side. The clavicular part is more obvious in attempting to approximate the chin to the sternum in flexing the head. Note that spasm or shortening of one sternomastoid will pull the head to one side, producing torticollis. The trapezius lies posterolaterally and forms the web between neck and shoulder. It is more conspicuous if the head is extended against resistance, or if the shoulders are shrugged. Note that the upper border of the mid-clavicle is not occupied by either trapezius or sternomastoid. A supraclavicular fossa occurs above this area. The anterior border of the trapezius and both borders of the sternomastoid are important in defining the two major triangles of the neck. Thus, an anterior triangle is outlined by the anterior border of the sternomastoid, the inferior border of the body of the mandible, and the midline of the neck. A posterior triangle is outlined by the posterior border of the sternomastoid, anterior border of the trapezius, and mid-third of the clavicle. For locating significant structures of the neck, these major triangles are subdivided into minor triangles by two other smaller muscles, the omohyoid and digastric. The superior belly of the omohyoid runs from the lateral hyoid to the anterior border of the sternomastoid at the level of the cricoid cartilage. The muscle then passes under the sternomastoid. Its inferior belly crosses the posterior triangle from the junction of its lower quarter and upper three-quarters, to where the anterior border of the trapezius meets the clavicle. The digastric has an anterior belly that passes from the digastric fossa on the deep aspect of the mandible adjacent to the mental symphysis to the lateral hyoid at its greater cornu, or 4 centimeters from the midline. From this, the posterior belly runs up and back to the digastric notch, which lies deep to the mastoid process and sternomastoid muscle. The inferior belly of the omohyoid subdivides the posterior triangle into a small subclavian triangle below and a large occipital triangle above. The subclavian triangle corresponds to the supraclavicular fossa, already mentioned as lying between trapezius and sternomastoid at the clavicle. In the triangle, the pulse of the subclavian artery can be felt with pressure down, back, and medially on the first rib. The upper and middle trunks of the brachial plexus can be rolled under the fingers on the underlying scalenus medius muscle. Supraclavicular lymph nodes, if enlarged from disease of the mammary glands or face, may be palpated in the triangle. The apex of the occipital triangle is at the superior nuchal line, where trapezius and sternomastoid meet. Its borders are these muscles and the omohyoid. Near the apex, the occipital artery crosses the triangle. The spinal accessory, or 11th cranial nerve, emerges from deep to the sternomastoid at the midpoint of its posterior border. It passes obliquely down across the triangle and under the trapezius about 5 centimeters above the clavicle. Cutaneous branches of the cervical plexus also emerge at about the same point. They pass upward, forward, and downward. Note that if the spinal accessory nerve is damaged in the occipital triangle, the trapezius is paralyzed. The shoulder then droops and is pulled forward and medially by pectoral muscles. The anterior triangle is subdivided into digastric, submental, muscular, and carotid triangles by the omohyoid and digastric muscles. The digastric triangle is outlined by the two bellies of the digastric and the inferior border of the mandibular body. Its major contents are the submandibular salivary gland, with the facial artery passing deep to this and over the mandible into the face, and lymph nodes. The mylohyoid muscle forms much of the floor of the triangle. The submental triangle is outlined by the anterior bellies of both digastrics with the hyoid below. The roof of the triangle is the mylohyoid, which is also the floor of the mouth. Lymph nodes are the only content of the triangle. They can be palpated if abnormal. These nodes drain the tip of the tongue in particular. The muscular triangle is outlined by the omohyoid, sternomastoid, and midline of the neck. Its major contents, the hyoid bone, thyroid, and cricoid cartilages, and the trachea, have already been described. The thyroid lobes lie on the lateral aspect of the cartilage, on its laminae. If enlarged, as in goiter or malignancy, they may be palpated from behind, with the neck flexed and the sternomastoids, which largely cover them, displaced laterally. The isthmus that connects the lobes crosses the midline at tracheal rings 2, 3, and 4. The carotid triangle is outlined by the digastric, omohyoid, and sternomastoid. Its major contents are the carotid sheath, which encloses the bifurcation of the common carotid artery, and the internal jugular vein and vagus nerve. A line from the sternoclavicular joint to a point midway between the tip of the mastoid process and angle of the mandible marks the course of the common carotid artery and its division into external and internal carotid arteries. It is initially deep to the sternomastoid, but becomes relatively superficial in the carotid triangle. The bifurcation is usually in the triangle, at the level of the upper border of the thyroid cartilage. However, it may be 2.5 centimeters higher in some individuals. The pulse of the carotid vessel can be detected in the hollow between the larynx and sternomastoid in the carotid triangle. The pulse of the common carotid can be felt and the artery compressed by pressure back against the long anterior or carotid tubercles of the transverse process of cervical vertebra 6. These lie deep to the anterior border of the sternomastoid at the level of the cricoid cartilage. The internal jugular vein has a course similar to the common and internal carotid arteries, lying lateral to them in the carotid sheath. Deep to the sternoclavicular joint, it is joined by the subclavian vein to form the innominate vein. The external jugular vein lies in the superficial fascia, deep to the platysma. Its course is marked by a line from just behind the angle of the mandible to the clavicle at the posterior border of the sternomastoid. Thus, it crosses this muscle obliquely and vertically. It joins the subclavian vein at the anterior border of the subclavian triangle, just above the clavicle. The vein may be visible when expiration is attempted, but the breath is held. Note that abnormal lymph nodes of the deep cervical chain may be palpated along the course of the internal jugular vein. The course of the subclavian artery in the neck is on a line from the sternoclavicular joint that arches up 1 to 2 centimeters above the midclavicle in the supraclavicular fossa. It then descends toward the axilla, lying on the first rib where its pulse can be detected. Suicidal throat cutting usually occurs at a level between the hyoid bone and thyroid cartilage, with severance of the left sternomastoid and superior thyroid vessels. Less often, the carotids and internal jugular are incised. This concludes the demonstration of major topographic features of the neck.